Well, thank you, Bob. I see a lot of familiar faces in the audience, so I'm glad to see you all out here hearing a serious topic like this on a beautiful day in Nashville. So I'm going to talk a little about the brain and how it works and how it's affected by aging and by Alzheimer's. These are my disclosures. I don't do any drug company work anymore. I will talk for food. So I'm going to give you a very quick overview of the brain and how it works, of memory, what memory is, how memory changes with aging, which we call mild cognitive impairment, and then how it's affected in dementia or Alzheimer's disease, and then a little bit about stroke and how stroke affects the brain and how we recover from a stroke. So I'm going to start with what higher cognitive or intellectual functions are. And I feel a little hesitant to say this in a church, but at least in practice every day, we think of the brain as the organ that gives rise to thoughts and feelings, personal identity, free will, that these are all the result of an assembly of nerve cells in the brain. This was Francis Crick, the Englishman who won the Nobel Prize for DNA, his quotation. Of course, it doesn't mean there isn't a divine inspiration behind all of this, but it's how we analyze the workings on a day-to-day basis. So this is from a set of slides that you can get free from Mayo Clinic, just showing the brain there and a little diagram of the cortex. Let's see if I can use the mouse to show the cortex. So there are as many as 100 billion neurons, and they all have very complex interactions. So it's supposedly more nerve cells and pathways than there are stars in the known universe. And a majority of these are in the part of the brain we call the association cortex. And I'll come back to what that means. First of all, they're first level or unimodal association cortical areas that have to do with a specific sensation, like vision, hearing, feeling, touch to the body, smells, etc. And then there are so-called heteromodal cortex that associate things from more than one of these. There are really only two heteromodal areas. One is in the parietal lobe, and it's the area where we connect auditory and visual things. For example, when we learn to read, we've learned how to speak first, but we learn to associate a written symbol with something we've stored in the auditory modality, and we learn how to read. And it's only possible to do that through this heteromodal cortex in the parietal lobe. The other one is in the frontal lobe, and it's the one that coordinates the rest of the brain, how to do things. And interestingly, if you look at comparisons of animal brains, monkey brains, ape brains even, to human, the two areas that have enlarged the most are those two areas, the parietal cortex and the frontal cortex. There's one more cortical area. It's called the supramodal cortex. It's in the base of the frontal lobes, and it's the part that integrates internal sensations, bodily sensations, and drives and emotions with external stimuli from the environment. And if you think about it, that's kind of the sine qua non for consciousness. I mean, to be conscious, you have to connect internal feeling states with the external world. And it oversees even this frontal cortex that programs what we're going to pay attention to, what we're going to give priority to, how we're going to sequence our attention. And in the words of Frank Benson, it's the part of the brain that anticipates, conjectures, ruminates, plans for the future, and fantasizes. Again, what we think of as the person. So it's the brain behind the brain, if you will. And this is just a picture of the different lobes of the brain, frontal in pink, and parietal in yellow, and occipital, I guess that's a sort of a purple, and temporal lobe in a bluish green. And then you see nerve cells, and you see synapses where nerve cells communicate, and they communicate via these neurotransmitters, just shown as dots. So what's memory? Well, memory is defined as the ability to store and retrieve information. So those are two different processes, storing it and then being able to retrieve it. And traditionally, there are three stages. At least this is the way a neurologist would explain memory. It doesn't fit exactly the way some cognitive scientists explain it. But we have an immediate memory that we call working memory or perhaps attention. And that's, how much can you keep in your immediate store? For example, if someone tells me a telephone number and I have to walk across the room to where the phone is and then dial that number, phone numbers generally have 7 digits, and just by coincidence, that happens to be the limit for most people for immediate memory, 7 digits forward. And I find that as I get older, it's a little harder to do that than it used to be. It used to be effortless. Now it requires some effort. And that's a frontal lobe function, that immediate memory. And it's affected more by things like stroke and head injury than it is affected by Alzheimer's. Eventually, it's affected by Alzheimer's too. On the other hand, short-term memory, also called recent or episodic or declarative memory, this requires structures in the medial part of the temporal lobe, the hippocampus and amygdala. I'll show you a little more about that as we go along. But memories have to be stored if you're going to store them for later retrieval using this mechanism. And then long-term is, where did you grow up? Who was president during World War II? Common knowledge things. Those are stored probably all through the cortex. So they have to be activated and then brought into consciousness. So the newer classification would call what I've just called short-term, they'd call explicit memory. But explicit memory means it's conscious, and there are two types, both the episodic memory, what you had for breakfast this morning, and the semantic memory, who was president during World War II. They're conscious. And they involve the circuit. I'll show you a diagram of it in a minute rather than read out the structures here. The amygdala, which sits next to the hippocampus, that has to do with emotional memory. So if there's a memory that's tinged with fear or with hatred or with anxiety, that memory is going to pop up quicker because the amygdala will stimulate it. And then there are types of memory that are implicit. Motor is a big part of that. So if you learn how to ride your bike when you're a kid, you never forget that. I mean, it may take a little bit of refreshing, but you'll be able to do it again. And even people that have memory loss from strokes or head injuries or even Alzheimer's disease, they may not even know that they remember how to ride a bike, but you put them on a bike and sure enough, they go ahead and ride it. So procedures are thought to be programmed in different parts of the brain, in the basal ganglia and in the cerebellum. Classic conditioning, Pavlov's dogs, you ring a bell and then you give the dog a biscuit, and the dog salivates when it hears the bell. So the unconditioned stimulus is the biscuit, the conditioned stimulus is the bell, and that's thought to occur through the cerebellum. So that's not disturbed by diseases that affect memory. Probabilistic classification learning, that's like given 7 facts about the weather and then predicting whether tomorrow is going to be a nice day. We do that unconsciously, and the basal ganglia have something to do with it, and it's impaired in diseases that affect the basal ganglia like Parkinson's disease, even if memory seems to be okay. And then priming, so I give you words to remember. One of them is doctor, and then I put up on the slide nurse. You're going to remember doctor better. That's called priming, and that works through the cortex of the brain, not through this medial temporal region. So I guess I've succeeded in convincing you that memory is complicated. How can I make it simple? Well, Andrew Budson, who's in Boston, at Boston University, he wrote a review paper with Price in the New England Journal. And he refers to the medial temporal lobes as the filing cabinet for recent memory. And then other cortical regions have the filing cabinet for all other remote memories. So if you just learned something in the last few days, it's going to be in the medial temporal lobe. But if you learned it 10 years ago, depending what it's about, it's going to be somewhere else in the cortex. We know, by the way, if when they do epilepsy surgery, if they stimulate the cortex, memories pop up, almost like Proust, remembrance of things past. A very vivid memory will come up. And then the frontal lobes are the file clerk. So you go to the library and you want a book, it's the file clerk that finds it for you, and the file clerk finds where it is, retrieves it, and brings it back into consciousness. So this is the circuit that I was talking about. Let me see if I can point to things. So the hippocampus is here. It has a long front-to-back dimension in the medial temporal lobe. And then it connects via this white matter path called the fornix. There's a way station right around here in the frontal lobe septal area, and then it goes to the mammillary body. Then the mammillary body is part of the hypothalamus. From there to the thalamus, anterior nucleus. From there to the cingulate cortex of the frontal lobe. And then back through the cingulate gyrus back to the hippocampus. So it makes a circuit called pape circuit. There's one in each hemisphere. So if you damage one, the other one can compensate if you're a young person. If you're an older person, it may not compensate so well. So if you have a stroke affecting the temporal lobe, you may not recover as well as an older person as you would as a younger person. Also, in epilepsy, they do surgery and take out that part of the temporal lobe. And although patients who have epilepsy surgery are young generally, you can test them and show that when the left medial temporal lobe is removed, people have more trouble remembering words and verbal memory, in other words. And if it's the right hemisphere, they have more trouble remembering nonverbal things like faces and pictures and routes to locations. So you may have heard of a patient called HM, who back in the 1950s was operated on in Montreal with a brand new epilepsy surgery, and they took out both medial temporal lobes. What's interesting to me, this was from an MRI from a paper that Suzanne Corkin, who was the neuropsychologist who tested him immediately and for 50 years thereafter, she wrote this paper in 2002. He died, I think, about a year ago. And he contributed a great deal because he was a research subject for many different studies of memory. But this is an MRI done in somewhere close to 2002, and you can see on this axial section, this is the area in the left hemisphere that was removed, and this is the area in the right hemisphere. It's very small, at least it looks small. On the coronal view, you still see a little bit of hippocampus on both sides, but here you can see on the sagittal view it's been cut off. Very small surgery had profound effects on him. He could never remember, form a new memory thereafter for the rest of his life, and he lived a long time. And he still remembered things from prior to his surgery, but after the surgery, only very minimal new information. So what about as we get older? Well, we know that the hippocampus is one of the areas that aging affects preferentially, these nerve cells in the hippocampus. And that causes reduced short-term memory. There's also aging in the frontal lobes, and that type of memory has to do more with recall than recognition. So if I give you 3 words, and I wait 5 minutes, which is something we always do at the bedside, and then I ask you what those words were, you have to recall them, and that's hard. But if I say, well, you know, one was a fruit and one was a piece of furniture, you're more likely to pick it up because then you have some recognition of it. Or if another test that's commonly given, you give 10 memory words, and then later on you give 20 words, which includes the original 10, and I say, have you seen this word before? You know, you'll do much better on the recognition task than on the recall task. So what about we baby boomers? And there are a few of those in the audience, I think. And We used to call it the Post-it note dependency syndrome. I think people are moving past Post-it notes now, and they're using their cell phone and putting a reminder in the calendar. At least that's what I do. Forget where you parked your car in the parking lot. You dial a number on your phone and you forget who you've just called. You're always searching for your eyeglasses. You call your children your pet's name and vice versa. You go off to work in the morning and you forget your phone or your umbrella. These are all called senior moments. I think we all have them from time to time. I like to think they're because our minds are too busy and we're thinking of other things. So when you look at memory in aging, there's certain things that are resistant. So we already talked about motor abilities having a separate area of the brain where they're stored, and they're very resistant to aging. Professional facts. So if I read a research article on stroke today, I will remember the facts of that because they kind of fit into a framework. I have a tree of knowledge and I can put that as one leaf on a branch, and it fits in better, and I tend to remember it better. Whereas if I read something I know nothing about, I don't remember it. And I don't know if you've all have noticed that, but I certainly have. Autobiographical information, you tend to remember your own history. Semantic knowledge, again, like the president during World War II, vocabulary is very resistant. So if I give you a word, you can define that word. If I do it the other way, if I give you the definition and ask you for the word, that's harder, and that's where we all start to lose as we get older. Also, oral reading. Even people with Alzheimer's disease can usually read aloud. And so both of those, vocabulary and oral reading, are used to estimate pre-morbid IQ in people that have lost function, because they tend to stay about the same. Also, remembering the gist of something, but not remembering all the specific facts, that tends to be better. We can prime by repeating things, and we call this crystallized intelligence. It doesn't change that much. Now then there's sensitive abilities. So trying to learn unfamiliar, new information about something we don't know about. Naming of uncommon objects. Series naming. So there's a test we sometimes do at the bedside where we say, name as many animals as you can in a minute. That's a little harder. You have to think to do that. The other one is not just semantic categories like animals, but words that start with a given letter. Like, I want you to name as many words as you can in a minute that start with the letter F. That's a lot harder. In Alzheimer's disease, the series naming, like animals, tends to be more effective than the letters. In frontal lobe diseases, it's the opposite. So memory content is more superficial and concrete with aging. Remembering to remember, that's a problem. My wife says, when you go out, don't forget to stop at the grocery store on the way back and get this. Well, of course, I'll drive home and forget to do that. Or you walk into a room and you know you went there to get something and you can't remember what it was. And all of these are called fluid intelligence. They change more easily. They're not crystallized. So you have to remember that difference. So how can we enhance our memory? Well, it is important to be mentally active and to learn new facts all the time. Now, I was advised by my wife that when I spoke to this group, I better know something about all these new programs for keeping your memory active. And every morning as I listen to the NPR news, I hear about lumosity. I think it ought to be luminosity, but it's lumosity. And there was a recent article in the New Yorker by Patricia Marks, which I recommend if you're interested in this area, because she interviews people that have various programs and takes tests herself. And these names on here are all names of specific programs. Most of them are not free. You have to pay to do them. Lumosity, I think she says, is $14.50 a month to join. And then you do these mental exercises. And there are a whole lot of them. The last one, DAKIM, I actually tried that one myself. I met the originator of it. And it involves, you can do it on a computer or on an iPad or similar tablet, and you'll click on a picture and it will show you a person, or it will be a little bit of a song from a musical, and whatever it is, if you identify it, then they go to similar examples and it gradually gets harder. And you just keep doing that. It seems like it's a good exercise. They claim that even people with Alzheimer's kind of get into this. If you, for example, if they play songs from musicals from when they were young, they tend to really get into that and start remembering things that they hadn't thought about in a long time. So there may be some benefit to these, but none of them have been subjected to good randomized clinical trials that would prove whether they're effective or not. Actually, she says there's some studies that are positive and some not positive. And some of them are expensive. So we go from normal aging to what's called mild cognitive impairment, formerly called benign senescent forgetfulness. It's not always benign, though. But we try to distinguish between normal aging, which we call the worried well. I mean, we all worry about our memory. Most of us are all right. Versus, which is age-associated memory loss, which is a normal phenomenon, versus mild cognitive impairment, which is defined by subjective memory loss, but also objective memory greater than 1 standard deviation below normal on testing. Part of this definition is that your overall intellectual function is normal, you have no other gross cognitive deficits, you don't have a dementing disease, and this bedside test we do, the mini mental state exam, the score should be more than 24. The MMSE is something I criticize a lot, but it's used so widely that you have to use it for reference. But it's very education dependent. I mean, if you didn't finish high school, probably 27 out of 30 is a normal score. And if you graduated college, you really should be 30 out of 30 on this test. So you can be 28 or 29 out of 30 and have lost a significant amount of your intelligence, and you could still qualify, I think, as mild cognitive impairment. The incidence increases with age. It's under 10% at age 40. It gets higher and higher as you get older. And there are two schools of thought about what it means. Riesberg said that 95% of people with MCI are unchanged after 3 years. But Ron Peterson, who's at the Mayo Clinic, did 2 different studies, one of which was a drug study. And in his series, 12 to 16% convert to Alzheimer's disease within 3 years. I mean, per year, rather. Which means that it's roughly half over 5 years. Which is not a good statistic, you know. It's not the greatest outcome. Though there are always people who, at 10 years, are still doing fine. So it's not a death sentence, but it does have something of a reduced prognosis. So I don't think they all become early AD. Some people do think that. So Dr. Peterson did a trial with donepezil. That's the generic name for Aricept. It's a drug that increases acetylcholine in the brain and it improves memory. And he found only a modest benefit after 1 year and none overall at 3 years. But people who had this gene called ApoE4 and who are more likely to have Alzheimer's disease, they did show benefit at 3 years. That study also had an arm with vitamin E, which was touted for improving aging and memory, and vitamin E had no effect at all. There was a similar trial with another drug called galantamine. That used to be under the trade name Razidine. It's been generic, though, for a long time. And that one was stopped because there were a couple of deaths in the, well, 13 deaths in the drug company arm, and I mean in the drug arm and 2 in the placebo arm. So the FDA has not approved any drug for patients with mild cognitive impairment. Now what about Alzheimer's disease? So Alzheimer was a German physician. He described this disease in 1907. It was a single case report. I always tell my residents that if you see an unusual case, don't be hesitant about reporting it as a case report. You never know what it will turn into. He thought it was a rare disease. It was a lady who was 51 who had psychiatric symptoms, depression and hallucinations. She also had language difficulty and disorientation and memory loss. And when she died, she had this pathology of plaques and tangles. I'll show you that in a minute. So what about Alzheimer's? Well, we think it's a continuum, that it starts with this mild cognitive impairment of the, there it is, the amnestic type. That means, amnestic means it's predominantly short-term memory loss. There are other types of mild cognitive impairment. So in that category, the patient has mild memory loss, but really nothing else wrong. They can still function. They can usually still work, unless their job is one that requires tremendous memory. And then you go into the mild Alzheimer's phase, and still at that phase, it's mainly memory loss. But you begin to have some trouble with daily functions that are memory dependent, like remembering where you have to be at a certain time, or remembering how to travel places. That becomes a little difficult. But you can still do most functions. When you get into the moderate stage, there's more memory loss, there's word finding trouble, there's also some functional difficulty. You know, activities of daily living are affected, and those patients generally can't live alone anymore. They need supervision. And then when you get to the advanced stage, of course, the patient is usually in an institution unless they have an unusually good caregiver situation at home. So later stages are not a happy area. So Alzheimer's disease is the most common dementing illness. It's about 50 to 60% of all the cases. And beyond that, I think another 15% or so are mixed Alzheimer's and vascular disease. So I'm going to talk about stroke a little later on. So there are more than 5.5 million people in the United States who suffer from Alzheimer's disease. Of course, the population is aging, so it's getting more common. I think it's also more recognized because in the old days when children kept their parents at home and lived in the same place, you know, they were more likely to just think of it as a consequence of aging and not as a disease. You know, now children are all working or they're living in another city, so it's just much more apparent in society. About 1 in 8 people over 65 has memory impairment. About 1/3 of people who die have Alzheimer changes at postmortem. There was one community study in the Boston area. These were people living at home that found that over age 85, almost half, I think it was 48% of people had dementia. So it's very common in the aging population. And it's projected to increase. I'll show you that in a minute. Very high cost illness. So this is a projection of what Alzheimer's is going to do over the next few years up to 2030, which is not that far away. And you can see that the groups that are increasing the most are the older groups, the 75 to 84 and the 85 plus. The the 65 to 74 is increasing less. So it really is a phenomenon of the aging population. Now, what happens in the brain? I can't go into great detail about this, but there are certain areas. We think of it as a general aging problem, but the way diseases in the brain go, they tend to pick out certain populations of nerve cells. And, you know, we see examples of that. I mean, motor neuron disease, or ALS, affects just motor nerve cells. Parkinson's disease affects cells in the basal ganglia. This disease affects cells in the brain, and it's in two or three areas. It's in those association cortical areas that I mentioned before, particularly the parietal lobes is where you see the changes early in the cortex on a brain scan, to a lesser extent the temporal lobe near there. This is not the hippocampal area, although that's affected too. but the lateral temporal cortex. Also the frontal lobes. And then there's some deep areas that you can't see on that diagram. The hippocampus that we've talked about, which has so much to do with memory. And then there's some basal forebrain nuclei, so-called nucleus of Minor. And they project widely through the cortex. We know that the transmitter in those pathways is acetylcholine, and it seems to have to do with the memory loss that happens in the disease. So here I've shown you the gross brain and also microscopic. So on top you see on the left, it's hard to say a brain is normal when it's sitting out on a table, but let's say the owner of that brain died of something else, and the brain looks fairly good in terms of the structure. On the right, you see a brain of someone who died with Alzheimer's disease over years. And even on this gross picture, you see this would be the central or Rolandic fissure, and the motor cortex in the precentral and the sensory cortex on the postcentral gyrus, they're somewhat spared, whereas the parietal lobe is more atrophied, and so is the frontal lobe. And then microscopically, and these are the changes that Alzheimer wrote about in 1907, on the right are silver stains showing plaques, silver staining plaques that are made up of broken down nerve cell components and then astrocytes, the cells that kind of they attempt to make scars in the brain. They don't do a very good job of it. And then over here are some remaining nerve cells, neurons, that have what are called tangles, microfibrillary tangles. And those are the two hallmarks of the pathology of Alzheimer's disease that he described and that we still see. This is a PET scan. Now, it's a type of brain scan where you're using an isotope. In this case, it's an isotope linked to glucose. So it's showing you where sugar molecules are taken up in the brain, so where the brain is metabolizing, where it's active. And you're seeing this, where the two arrows are, the parietal lobes, this biparietal reduced metabolism that's characteristic of Alzheimer's disease. So we've been doing that type of PET scan at Vanderbilt for many years now, since the early 1980s, I think. Now this is a newer kind of PET scan that we're not doing yet. It was originated at the University of Pittsburgh compound B, and it binds to amyloid. So it shows you where amyloid protein is deposited in the brain. And you see on the left an Alzheimer patient, it's lighting up, and then on the right, the control, it's not. Now last year, the FDA approved another ligand called Amyvid that's commercially available, which does the same thing, maybe not quite as accurately. The FDA approved it. However, CMS, Medicare, decided not to pay for it because they feel that the research isn't there yet to justify this being done on large numbers of people. And you know, I have to agree with that. I mean, we don't know if you have, say you're 65 and you think your memory's a little impaired, and you get this scan and you have some amyloid in the brain. Does that mean you're going to have Alzheimer's in 5 years? We really don't know yet. We haven't followed enough people through research trials. We know that there are differences. I mean, in post-mortem studies, there are some people that have amyloid deposited and plaques and tangles who didn't have dementia in life. So it doesn't correlate 100%, the pathology, with how bad your dementia is. So we don't know if this scan is going to scare people unnecessarily at a young age. So it needs more research. So what can we do, those of us in this room, to keep from getting Alzheimer's? Well, I said before there are differences in how the burden of the disease affects an individual person. And we think that some of that has to do with so-called cognitive reserve. Cognitive reserve means if you're pretty high functioning to start with, you can lose a bit of your intellect and still function okay. So, I mean, college graduates tend to be later when they develop Alzheimer's than people with, say, a high school education. Second, physical exercise seems to improve the brain. How exactly? That's being studied. The fact, though, is not in dispute at all, that in multiple studies, physical exercise is the most important thing you can do to prevent dementia. So be active, get out and walk, do exercises, join a gym class, do jazzercise, go swimming, whatever you like to do. I think the trick is finding a type of exercise that's not a chore or a painful experience. So it not only prevents Alzheimer's, but people who already have it seem to have slower deterioration if they exercise. Diet may also play a role. So there are several studies on Mediterranean diet causing reduced incidence of Alzheimer's disease. There is some evidence that mental exercise is also protective, so those various programs we talked about may have some benefit. The other issue is the risk factors for heart attack and stroke. They are the same risk factors for dementia. I don't think we know exactly why high blood pressure increases your risk of dementia, diabetes increases your risk of dementia, high cholesterol, smoking, obstructive sleep apnea. We don't know exactly why, but we know it's a fact. So if you want to prevent both Alzheimer's and stroke, you should eat a healthy diet, exercise, get enough sleep, and control your vascular risk factors. So what do you do to prevent dementia? You do exercise, physical and mental. You eat a healthy diet. Some people think antioxidants are important. I said before, vitamin E hasn't been proved, neither of any of the other antioxidants, so you can try that if you want. The resveratrol that's in red wine, some people believe in. I think all these things are not well proved. More important are the exercise, the getting enough sleep, watch your blood pressure, your sugar, your cholesterol, don't smoke, don't drink excessively. These are more important than brain games. So what can we do if you have Alzheimer's? Well, we're not doing too well. So how much time do I have? I better speed up a little. So we have drugs that increase acetylcholine. I mentioned donepezil or Aricept. They have been proved to help memory a little bit, but they don't treat the disease, so the disease still gets worse over time. There's memantine or Namenda. It's a glutamate receptor blocker. We don't know exactly how it works. It seems to cause some symptomatic improvement. There are attempts at modifying the disease by preventing amyloid deposition in the brain. Amyloid is this protein that's overrepresented. And there have been vaccines. The active vaccines were withdrawn because they caused encephalitis. There are passive vaccines, antibody infusions. So you raise an antibody in mice, and then you humanize it, and then you give it to people, and it gets rid of the amyloid. And it seems to do that to some extent, but they have not succeeded in showing clinical benefit yet. There was just a major negative trial this past year. Intravenous immunoglobulin, it's an anti-inflammatory. That hasn't panned out. Stimulation of the brain through electricity or magnetism, that hasn't worked. So there's a lot of research, but as of 2013, we do not have a disease-modifying treatment. I think that slide kind of speaks for itself. So when do you stop people from driving? There are a lot of studies on that. I mean, there's some obvious things. You know, if you've wrecked your car once, if you've had moving violations, you know, gone through red lights, etc. But also, if your mini-mental is 21 or below, it's questionable whether you really should be driving. They do driving evaluations at Vanderbilt. So I'm going to spend a few minutes on stroke and then stop. So there are about 800,000 strokes every year in the United States. There are probably more than that if you consider silent strokes. There are probably 10 silent strokes for every clinical stroke. That's based on estimates from MRI scans. In terms of stroke treatment, we have a newly developing field of acute stroke treatment, both with intravenous TPA and with intra-arterial approaches. We're really working hard on that at Vanderbilt. But first of all, only a small minority of stroke patients get that treatment. And secondly, we're having trouble proving that that they work better than just IV TPA. I think they do in certain cases, but the methodology for proving it has been difficult. So there are 4.5 million stroke survivors in the US. That's almost as many people as Alzheimer's. Most strokes could be prevented with currently available knowledge. So stroke is not cancer. I mean, we're not exactly waiting for a scientific breakthrough. In maybe an acute treatment we are, but in how to prevent a stroke, we really know how to do that. This is the imaging you can do with MRI in an acute stroke. Just on the left is the diffusion image that shows where the stroke is. On the right is a perfusion scan that shows where the perfusion is below the limit for tissue viability, which is in red, and the greenish colors mean that it's reduced perfusion but not irretrievable. So you can base acute treatment on that. People that survive a stroke, about 10% of them get by with no noticeable disability. About 40% have mild disability, 40% mild, moderate to severe, and 10% are in long-term care. And half of them have motor disability, or usually one-sided paralysis. About 20% have cognitive or language problems. And about a third, after a year, have cognitive problems. We're not sure exactly why that is, but we do know that if you have a stroke and you have any degree of Alzheimer's change in the brain, the two kind of interact with each other and it lowers the threshold to becoming demented. So only 10 to 15% return to work, which is a sad statistic. And of the cost of stroke, an awful lot of it is in rehab. Okay, I don't know if I have time to, when do I have to stop? Okay, so I'm just going to go through an experimental model. We think that you recover from stroke through plasticity in the brain. When I was asked to do this talk, they said, can you talk about brain regeneration? Well, this is what we can do. We have plasticity, which is the adaptive capacity of the central nervous system to modify its organization and function. So there's recovery based on parts of the brain that are not getting enough blood supply but are not completely destroyed, and they recover. We have areas that are connected to the area of the stroke that are depressed after a stroke. That's called diaskesis, and that can come back. And then we have things like swelling that are preventing the brain from working. Those are all active in the first week or two, and then after that, recovery has to do with reorganization. So, can we regenerate cells? There are stem cells in the brain. It's not as if there aren't. The problem is if you have an area of damage, they don't have a way to migrate to where they're needed. And we don't think the stem cells play much of a role in recovery as of now. There are experiments based on transplanting stem cells in areas where they can better establish connections, but that research is in a very early stage, I would say. Now, we know if you make a stroke in a monkey, squirrel monkey, the cortical area for control of the opposite upper limb shrinks. So if you stimulate the brain, the area where you can elicit a movement is smaller. And then if you make that monkey exercise the weak limb, it grows again. Also, if you constrain the other limb, the good limb, so that the monkey has to use the weak limb, that seems to make it come back even better and faster. And if you do the restraint without the exercise, it doesn't work. So this is the basis of something called constraint-induced therapy that actually was developed in some animal research at University of Alabama and then later done in people. And there have been PET scan studies in people showing that there's a similar shrinkage of motor cortex after a stroke and then growth as recovery and rehabilitation take place, and that even passive exercise can help it along. So Dr. Taub at UAB developed this idea, and it's now used widely around the country. The same principle can apply to speech and language. We know after a stroke that the right hemisphere tries to activate as if it's going to subserve language when the left hemisphere is damaged. But it seems like if the right hemisphere stays active, the recovery isn't as good. It's a second best strategy. That if you can recover adjacent areas in the left side of the brain near where language started, the recovery is much better. So all of this is to say that there is such a thing as recovery after a stroke. There is plasticity in the brain, even if there isn't regeneration of neurons. You know, I asked Jeanette Norden, who has given many lectures, I think, in the Osher series, and who's one of the best lecturers I've ever heard. But I asked her about, you know, how do you recreate neurons? She says, well, just tell them you can't do that. I didn't think that was the message that you all wanted to hear. And I don't think she would have said it that way either. So we can reorganize the brain. There is plasticity. And for normal aging, for prevention of both dementia and stroke, again, the important measures are physical and mental exercise, so stay active as much as you can, lead a healthy lifestyle, manage your vascular risk factors as well as you can. I read recently that stress is also a negative predictor, so if you can avoid stress in your life, that's good for avoiding later memory loss. Rehabilitative therapies help after stroke, and I think there's some evidence that even in Alzheimer's disease, speech and cognitive therapy can help people. They can help people accommodate to their deficits and to use spared functions better. And the future promises better ways to facilitate brain recovery and perhaps even regeneration, which is what we don't seem to know how to do right now. Well, thank you for your attention. Yes, sir.
5 minutes. What's the average age for stroke?
Well, the incidence of stroke goes up with age. So most commonly it's in older folks, but I think the statistics are about 30% occur before age 65, and that is spread through all the ages. We see strokes in children, strokes in young adults. The causes are somewhat different. You know, in older people it's atherosclerosis and heart disease and hypertension, and in young people it's some other different mechanisms. Yes, yes, sir. Right here. Concussions and dementia. That's an interesting topic, because you know there's been a lot of attention paid just recently to this so-called CTE, chronic traumatic encephalopathy, and you know you read about the National Football League players that have that. In the Alzheimer's disease studies, in some of them, having a history of a head injury is a predictive risk factor for dementia. Not every study agrees on that. I think what all the studies do agree on is head injury bad enough to cause loss of consciousness. If it happens multiple times, it's definitely a risk factor. So you know, it's something to avoid. It's a question that I think people face now is, you know, do you let your children play a sport like football the way it is organized now in the United States? Because it's a risk factor both for the subject I'm talking about and the subject the previous speaker talked about. A lot of people end up having knee replacements who played football. Yes, ma'am.
There's been some information, I'm not sure how correct this is, that they never thought that the glial cells were all that physiologically accurate, but they're finding that they really are, that maybe they're acting as the brain's waste management system. Can you speak to that?
Well, that's certainly true. I mean, when nerve cells discharge, they release potassium, and the glial cells sop it up again, and then give it back to the nerve cells in ways that make it functional again, make the nerve cell functional again. And you know, if you don't have that glial mechanism, then the whole thing doesn't work and the nerve cells run down. So that's true. It is kind of a waste management system.
And they were talking about how Alzheimer's patients maybe have a defect in that mechanism.
I don't know very much about that. I know that there is gliosis in the brain. When you lose neurons, the astrocytes enlarge and take over more But you know, if there aren't enough nerve cells, I don't think they can replenish what nerve cells there are enough, and they may actually physically get in the way of the nerve cells. But I don't know about a defect in the glial cells, but I'll try to look that up.
I hate to do this, and I know you're going to throw something at me, but we have to